So a 50-year-old female presented with extensive rashes all over her body for the past 1 day, and she was a known case of multiple myeloma and has been receiving bortezomib, cyclophosphamide and dexamethasone regimen for the past 4 months. And 1 day prior to the onset of the rashes, she had received lenalidomide. On general examination, she had tachycardia with a pulse rate of 134 per minute, where the remaining vitals were stable. There was extensive desquamation of skin all over her face and body. So this is the clinical picture of the patient at presentation. So you can actually appreciate that the whole of the face, the skin is completely desquamate. There's a lot of necrosis also all over the forehead. Coming to the lashes and the eyelids per se, you can appreciate that the lashes are completely matted. And the lower lid, you can appreciate there is ectropion. The lashes is completely matted. And also, if you look more clear, in the next photographs I will show you. So on ocular examination, we noted that there was the visual acuity in the right eye was 636 and left eye it was 612. And there was again, the lids were completely having poor skin, and the skins were exfoliating coming out, and the lashes were matted. Coming to the photographs of the right eye and the left eye, here you can actually appreciate in the right eye there was an epithelial defect which was a kind of a spindle shape in nature, and it was roughly 12 into 4 millimeter in size. Unfortunately, we did not have fluorescent angiography or fluorescent dye per se, so that we could stain them. The patient was admitted in ICU. And this is the images of the left eye. We also appreciate that there were multiple developing symblephrons. So based on these findings, a diagnosis of Stevens-Johnson syndrome was made, and the patient was started on intravenous fluid, antihistaminics, both topical as well as oral, and antibacterial medications were started on oral and the patients also underwent regular swipes using glass rods for breaking the developing symblephrons. And we also started topical as well as oral steroids, and there was immediate marked improvement in the following 5 days. The epithelial defect disappeared completely, and the skin actually healed up. This is just 5 days post treatment. So coming to the discussion, lenalidomide is an analog of thalidomide. However, compared to thalidomide, which is more commonly used, it is more potent, and it has more anti-angiogenic effect and has a better safety profile. Nowadays, it's kind of one of the first drug to go to for treatment of multiple myelomas. However, in the last few decades, only 3 cases have been reported of Stevens-Johnson syndrome. However, when you're talking about SJS, the degree of severe ocular SJS has never been reported. To conclude, lenalidomide, although rarely, but can cause severe form of ocular Stevens-Johnson syndrome. However, an early diagnosis with prompt management can yield satisfactory results. So this is the pre and post management images. These are the key points. That is, lenalidomide can induce SJS, and early detection is crucial. Supportive care is very essential. Ocular management has to be done properly, and multidisciplinary care is essential, where a collaboration has to be there between the dermatology, ophthalmology and oncology department. Thank you.
Thank you, Dr. Deepsekhar. So is it this lenalidomide is a routine?
So it's currently one of the go-to drugs for multiple myelomas. Nowadays, it's.
And what is the basic role of this?
So it's a thalidomide. Like it was previously thalidomide, it's a better potent variant of thalidomide. So this actually acts. It's a chemotherapeutic agent. So it typically restricts the proliferation of the blast cells. If you want the exact DNA, which level I'm not able to recollect as of now, but we usually do it. It's regularly used otherwise.
ये एंजियोजेनेसिस को रोकता है.
It has a part of it is antigenetic. It has a part of it is anti-angiogenetic, but it's not purely just based on the angiogenetic factor it's used.